schedule then. And after that, we are eagerly waiting for Dr. Manish, then Dr. Aditi.
Both are there, Dr. Chauhan, Dr. Manish,
Okay.
and Dr. Aditi and Dr. Parul Raina. All
Okay.
three faculty are there. We
Okay.
actually were looking forward to welcoming everyone and giving the mic to you if you would want to begin. Then, of course, we will share the background so far that Pallium India has been involved with.
Definitely. Dr. Manish has joined, I think, from INC.
Yes, he's there. Dr.
Okay, that's
Manish?
great. Good afternoon, sir.
Good afternoon. कैसे हैं आप?
All good, sir. Sir, really happy to see you. Dr. Aditi from Chamba has joined because yes, Dr. Aditi, I can see you. Yes, Shalini, I think we should start. This is the right time, and
Sure,
we are eagerly waiting that what your plans are. Thank you.
definitely. Dr. Jatin, would you want to begin
Yeah,
welcoming everyone?
yes, sure.
Yeah.
Yeah. So a very warm welcome to all of you to today's session. I am Dr. Jatin Bhukkal. I am working as the regional coordinator with Pallium India for the state of Himachal Pradesh. With me, I have Ms. Shalini. She's the national head of our facilitation department. And firstly, I would like to thank Dr. Gopal Chauhan for the initiative of organizing this orientation session for palliative care for the state of Himachal Pradesh. And there's a good news that I want to share with all of you. Pallium India has recently signed an MOU with the National Health Mission of Himachal Pradesh, and this is to strengthen the palliative care services in the state of Himachal Pradesh. And this would not have been possible without Dr. Gopal Chauhan's support. So a big thanks to sir again. And this orientation session has been organized to understand what palliative care is and what is the current scenario in the state of Himachal Pradesh and what are our plans forward to it. So I'm delighted to welcome. We have three esteemed faculties with us. We have Dr. Parul Rana from Sharda Hospitals, Uttar Pradesh. We have, of course, Dr. Manish Gupta from IGMC Shimla. We have Dr. Aditi Chaturvedi from Government Medical College Chamba. And Shalini, maybe you can, give a brief introduction of what already has been done in Himachal Pradesh with Pallium India. So I hand over the mic to you.
Sure. Thank you, Dr. Jatin. A warm welcome to everyone here. It's been a pleasure to have you all. बहुत खुशी हो रही है आप सबसे बात करके because this has been a journey which started actually in 2018 for Pallium India, 17-18, when for the first time with Dr. Rajgopal, I had visited Himachal Pradesh and we got to meet the then Health Secretary, Mr. Prabodh Saxena. And we were able to conduct a program, an opioid availability workshop in Parimahal, where he attended, and of course, a lot of chief medical officers from all districts had attended. So that was our beginning, and that's when we started working with Dr. Gopal Chauhan also. That carried on, and then we had a lot of. There is a group of district hospital doctors who had visited Pallium India Trivandrum for training in 2018. And we also had Dr. Manish Gupta. Good afternoon, sir. Very happy to see you that you're presenting today. We got a chance to host him and welcome him for a course in Trivandrum. We also had, along with him, a couple of other doctors who were handling palliative care in Tanda Medical College and now in AIMS Bilaspur, Dr. Muninder Negi as well. So this journey and this relationship has been since long, but I think formally we formalized it this year in March and we signed an MOU with National Health Mission. And all thanks to Dr. Gopal Chauhan that he invited us to work with him for each district hospital. The whole idea about Pallium India working with each of you is how we can work with you to enhance palliative care services for the state of Himachal Pradesh. Some of the beautiful work is already going on, and that's what Dr. Manish Gupta and Dr. Aditi Chaturvedi would be sharing with you in their respective institutes, how they are doing, what they are doing. And of course, we have Dr. Parul Raina, who's going to share her experience from Delhi. Uttar Pradesh. Noida and Delhi are very close, so they get confused. So she will be sharing, and the whole idea is that we bring best for you. We want to enable you by working with NHM for building palliative care services so that our patients who are there in Himachal, they get these services ASAP. So I would not take more time, and I would request Dr. Gopal Chauhan to kindly share his views about what we are doing right now and where does he see, what is his vision of seeing palliative care services in the state. Dr. Gopal, would you like to share something?
Yes,
Yeah.
Shalini. I think I am audible.
Yes, sir. You're audible.
Okay, thank you. First of all, I would like to thank Pallium India and my, colleagues from the state of Himachal Pradesh. Let us begin with, for the new people, those who have joined this initiative recently or are planning to join it. I would like to say that, we are in a trap of non-communicable diseases. And the NCD prevention and control, if we talk about risk reduction, management, early screening, diagnosis, treatment, and then rehabilitation. Palliative care is one of the most important component of this journey because sometimes we can understand that we are not able to prolong life of the individual. We are very clear that the patient is going to die, but how, because every person is having a right to live with dignity. It is the same thing that every person is having a right to die with dignity also. And what support we can provide to the individual at that point of time, so that he continues his journey till end in a safer manner, where his life becomes painless and he enjoys the life. Everybody of us will die at one point of time, and this is the entire journey between birth and death, that how we live it. Most important thing is, people, it was a time that whenever someone is suffering with a chronic disease, cancer, dialysis, CKD, COPD, that we were saying same thing, that now nothing can be done. But as of now, the science, with the evolution of science and technology and NGOs, those who are working in this field, palliative care has become very important. Yes, today we can say that we do have services. We do have something to offer to them, that we can make their life more comfortable. Second thing is, India is a developing country, and in context with Himachal Pradesh, the aged population is increasing. I am worried that our TFR has gone below 1.5. As of now, it is around about 1.3. We can say that we will be the first state in the India which will be having more than 60% more than 15% population will be elderly. And you know that how many them will require palliative care. This is, you can make the speculation that how difficult it is going to be for us to manage all these things with passage of time. This is the right time that we start thinking on those lines and start experimenting, start doing something, so that after 3-4 years we will be having a concrete plan which is evidence based, which is replicable, which is feasible. And yes, there is a palliative care program run by Government of India. Before that, we took help of the Pallium India. You will be doing some Google search that what Pallium India does. Basically, Pallium India is a non-government organization, institute also, and they are the collaborating center with WHO also. Shalini will tell more about it. But more important thing is, they are supporting many states in India, that how palliative care should be implemented in the states and at district and below district level. Government of India has drafted guidelines with the help of National Health Resource Center, New Delhi, and we are imparting training to the MOs, health workers, CHOs, and ASHA workers for palliative care. But you can see that the current MOU which we have signed with the Pallium India, that talks about top to bottom approach. It is not a bottom up approach. They will strengthen the top level institutes, our district level institutes. Then we will be going down to the civil hospital, then to the CSCs, and after that we will catch the PSCs. But simultaneously, we are screening people. We are doing the enumeration through ASHA workers, health workers. they will escalate the patient toward the higher institutes. It means that the gap which is in the MOU that we are already filling, and definitely if we will be able to provide or strengthen the services at district level hospitals, I think the escalation will be more. People will realize that we are able to provide better services in terms of palliative care services to the people. I think Pallium India will train our doctors. They will come to Himachal. We will try to send few doctors, which we have sent in the past also to Trivandrum to see the institute. And few of you will get the opportunity, like the previous teams. They will go to Trivandrum to see the institute, to study how do practice the things. But as of now, the agreement says that Pallium India persons will be coming to the state of Himachal Pradesh. They will train people here in Parimel also at district level. There will be also a bedside training also, practical examination also. And yes, of course, for that we need help from IGMC, from Tanda Medical College, from Nechok Medical College, and our bigger institutes in the state also. We will rope in, all the faculties so that we have a combo plan. Because I can say that there is nothing like a best practice in palliative care in India as far as the entire country is concerned. This is the right time that Himachal will move forward for this, and we will demonstrate the best practice, in the state, which can be replicated in other parts of the country. I think I welcome the entire team from Pallium India, and I welcome my colleagues from the state. I am lucky that we are having 50 participants, and we expect few more persons, especially for the persons, those who are from district level, the doctors. Try to understand that you will be providing the palliative care, in the district hospital. You will be trained further. We can understand that you are doing these things, but how to do it in a very good manner, or in a very practical kind of manner, so that people can get the benefit of these services. I think with this, I end here, and we are very eagerly waiting to hear from the experts. Thank you.
Thank you, sir. Thanks a lot for sharing your views. And now I would like to request Dr. Parul Rana from Sharda Hospital, Uttar Pradesh, to please start with her presentation. Dr. Parul Rana is an MD in anesthesia. She's currently working as the assistant professor in the Department of Anesthesia with Sharda Hospitals, and she's a fellow at Global Fellowship Program in Palliative Medicine by Pallium India, and she has a keen interest in chronic pain and palliative care. Dr. Parul, you may please proceed now.
Hello, good afternoon, everyone. Let me share my screen before I begin my topic. So yeah, good afternoon, everyone. I would like to congratulate everyone for this wonderful initiative in Himachal Pradesh. I have done my MD in anesthesia, and I was previously working in the Sharda Hospital, and I have finished my global fellowship program last year. I'll be talking today briefly about the palliative care. What does it mean? And what is the global scenario, and why it is required and why it is needed. So the term palliative is derived from the Latin word pallium, which means cloak. To palliate is to cloak or cover up the symptoms of an illness without curing it. And this meaning grew into the idea of alleviating or reducing the suffering. It was Dame Cicely Saunders, who was a nurse in UK, who brought the modern hospice term in 1948 and introduced the concept of total pain. And what does this total pain mean? The total pain means we're not only focusing on the physical aspects of the pain, but the emotional and how this pain means to the patient spiritually and how it is affecting the patient socially and economically. Cicely Saunders, after after working in the ward, saw the suffering of the people, and she realized the importance of this total pain. And it was Elizabeth Kubler-Ross who actually humanized how dying patients were considered and acknowledged. And as you, majority of the people know, the 5 stages of grief, which was introduced by Kubler-Ross, also known as Kubler-Ross model, which was actually first introduced in her 1969 book on death and dying. It was Dr. Balfour Mount, a surgical oncologist from the Royal Victoria Hospital of the McGill University in Montreal, Canada, who actually coined the term palliative care, which was to actually avoid the negative connotations of the word hospice in the French culture, and thereby introduce the Saunders concept into the academic teaching hospital. So, what is palliative care? WHO has not recently, in 2012, edited the definition of the palliative care. Earlier, the palliative care was only for the cancer patients, but now it is defined as an approach that improves the quality of life of patients, which includes both adults and children and their families who are facing problems associated with life-threatening illness. So it not only prevents and the relief suffering through the early identification and as well the correct assessment and the treatment of pain and other problems, whether it is physical, psychological, or social. So the palliative care encompasses not only the symptom relief, but also the spiritual existential care, also the advanced care planning, and as well the caregiver support and the bereavement care. So by this, we now understand that palliative care cannot be managed by a one person or a single doctor. It is always a team of healthcare professionals, which includes doctors, nurses, paramedical staff, as well as the social workers and psychologists that actually provides the palliative care as a holistic care to the patient. So the next question comes, when should the palliative care start? Earlier, the older concept was palliative care was synonymously translated to the hospice care, where initially the curative treatment was done, and when no other modality was there, the patient was sent to the hospice care. But the new palliative care model means the palliative care is initiated as soon as the patient is diagnosed with any life-threatening illness. And it is continued throughout the patient's life, including the terminal phase, and it also carry forward through the bereavement process to provide the palliative care and the bereavement care to the caregivers. So the palliative care means it is across the continuum of the care from the beginning of the suffering, any health-related suffering, to the end. So what is the role of us as a healthcare profession? Now, with the modern modalities and the treatment, we all are focused on the curative aspect. And slowly, we have forgotten what it means to care. So it's the high time we go back to what Hippocrates has said, that cure sometimes, treat often, and comfort always. Palliative care can be provided at the primary level as well as the secondary. What it means at the primary level is what is done and will be done at the primary healthcare services or in the district hospitals, where the palliative care can be provided by any physician in the major district hospitals by all the physicians. Whereas secondary palliative care means when any symptoms is difficult to control, or any end-of-life care planning, or a communication regarding the difficult challenges, only then a specialist palliative care is included. So a palliative care can be provided by all the physicians. Now, the question comes, what is the need of palliative care and why we are discussing and talking about it? So palliative care is now considered as an essential element of the universal health coverage. It has been the target of the 3.8 of the Sustainable Development Goal, which addresses the need of the palliative care and pain relief. What is the burden of the serious health-related sufferings? In the lower middle income countries, about 51 million people are in serious health-related sufferings per year. And in that, 7 to 10 million people who are Indians are in the serious health-related suffering. And it is only 14% of the people who need palliative care are currently receiving it. And majority of the adults who need palliative care, which is 76% approximately, are in the lower middle income countries. Also to highlight, it is a non-communicable disease, which account for almost 69 to 70% of the palliative care need. So this is the graph which shows the worldwide need for the palliative care. Here we can see the 28.2% is the contribution by the malignant neoplasm, whereas the rest is by the HIV disease, dementia, degenerative diseases like Alzheimer's, cerebral vascular diseases, chronic heart diseases, chronic lung diseases, and also a few by the congenital malformations. If we see by the age group, the children from 0 to 19 years old also contribute about 7%. So it is important that we don't forget the children, which also need the palliative care. Out of all the symptoms which are required to manage, pain and the difficulty in breathing are the two of the most frequent and the serious symptoms experienced by the patients in the need of the palliative care. In that, it has seen that 80% of patients with AIDS or cancer and 67% of the patients with cardiovascular or chronic obstructive pulmonary diseases will experience moderate to severe pain at the end of their life. So it highlights the importance of the opioids for managing the pain. This is the WHO pain ladder, which highlights that always we have to give the importance to the pain management. It has to be given by the mouth, by the clock, and by the ladder. But sadly, pain relief reaches hardly less than 4% of the needy in India, whereas India is the maximum export and the maximum production of the oral morphine. So this shows the distribution of the opioid morphine equivalent throughout majority in the South Asian and the European countries. Here you can see, whereas the USA and the Canada are overflowed and overburdened with the opioids, our country, which produces maximum oral morphine, is just shrunken with only hardly the 4%. Now the question comes, how we are going to tackle this? So the policy forms the umbrella of all this, with the triangle with education, drug availability, and implementation, which can lead to the outcome to minimize the health-related sufferings. So what are the policies? As we know that morphine has been included in the essential medicines, there are the policies and regulations by WHO, there are policies formed by the IAPC from the Pallium India to support and deliver the palliative care. We have drug availability in the form of opioid and oral morphine, which is managed by the pharmacists, drug regulators, law enforcement agents, and education forms the main importance to provide the palliative care. As we know, if we have the basic education and awareness in our community, people will get the idea what it is palliative care, and then they can ask about the palliative care and demand about the pain relief and other symptom sufferings. And how we're going to implement all these things by the opinionated leaders, trained manpower, strategic and business plans, resources and infrastructures, as we are doing it, and by the guideline measures. In India, we have already done much of the work, but it is highlighted that much is needed. There are national programs for the palliative care, NDPS Amendment Act in 2014, a national health policy in 2017 and 2019. It was that EdCom module, Attitude and Communication Skills module, was implemented in the undergraduate MBBS curriculum, so that right from the beginning of our medical education, we know how to communicate and how to manage the pain and how to relieve the suffering of the patients. And in fact, in 2021, this EdCom module has been included in the undergraduate nursing curriculum 2021 as well. So thank you so much, and wish you all the best and good luck for this wonderful journey ahead. And I would like to conclude this quote from the M.R. Rajgopal sir, who is the father of the Indian palliative medicine. He said that the most important fundamental principle of medicine is love, but modern medicine has rejected that word. And actually, the essence of care is love. Thank you.
Thank you so much, Dr. Parul. That was such a lovely session, and thank you for introducing to a lot of facts that we'll be discussing through the session today about drug availability, about why there is a need for not just end of life care, but all through, and also for all kinds of age groups that we need palliative care. Thank you so much for a lovely session. Dr. Jatin, all over to you.
Thank you so much, Dr. Parul, for this wonderful session. And if anybody has any questions related to anything, we have the forum open. You can put the questions in the chat box, and we'll also give a time to discuss anything if anybody has in mind later on. Now, I would like to request Dr. Manish Gupta, sir, to please begin with his presentation. Many of you already know Dr. Manish Gupta, but since those of you who don't know, Dr. Manish Gupta is the professor and head of the Cancer Hospital and IGMC Shimla. And I would like to request Shalini to please introduce her a little more.
Thank you, Dr. Jatin. Dr. Manish Gupta, it's been a pleasure knowing you, working with you for so long. I just wanted to highlight this to everybody here, that he single-handedly, when he had come here, learned about palliative care and gone back. I think he was the first person who really took over the charge of palliative care in Himachal. Though we had a unit running in Tanda Medical College much earlier, but that somehow couldn't continue with the placement of doctors and transfer of doctors. So Dr. Manish Gupta has, kept the flag on in RCC in Shimla. So, sir, thank you so much for all your efforts. And now we see in IGMC Shimla what a beautiful combination of anesthesiology and oncology coming together, looking after both cancer and non-cancer patients. So it couldn't have been done without your leadership. So we'll hear more about your work and how your center is taking it further. And I think, I'm not sure if Dr. Vinay Soumya is there, who works with you also, and he's the one partnering with you. But it will be great if you highlight how both of you work together. Please, thank you for coming.
Thank you, and thank you for the nice word. So, as you said, me and Dr. Momindan, we first always say, am I audible?
Yeah, Dr. Manish, if you can just increase the volume, it's little feeble.
Okay.
I'm not sure about others, but I am hearing it very low.
Hello, now it's okay.
No.
Okay, no problem.
Sir, if you can bring the mic little closer to your mouth, would that help?
Hello, now I'm audible.
Better, it's better. You can continue, sir.
Okay. So I was just as I was saying that me and Dr. Momindan, we probably 5 years back we visited Pallium. So because we got faculty holidays and during that time we visited Pallium, and it was an eye opener to us actually. though we were working in the oncology or radiation oncology or cancer hospitals for the last probably 10 years before. But what we were doing, what we have learned in during our oncology practice actually. So we were learning and doing. But when we visited the Pallium India, then actually we learned or we came to know what we should be doing actually. Not in the not only for the patients who are terminally ill, but for all the patients, because all of our patients require palliative care in one form or another. So, as Dr. Rana was showing us in presentation, that 1/3 of the palliative care patient comes from oncology actually, and we started when we started practicing palliative care. So, and we were fortunate that in our hospital, we were able to open up palliative care cell, pain and palliative care cell. And we were lucky that Dr. Somya is not present in this meeting actually, but he would love to be there. And he was posted as one of the consultant or assistant professor from anesthesia to our department as pain and palliative care specialist. So we now have a pain and palliative care cell where we send all our patients who are registered, who are registered with us, to have a go at pain and palliative care center. So at the outset, we make it a point that everybody is seen by palliative care physician. We have 2 persons at present working in palliative care. One is Dr. Somya and other is Dr. Ajay Sharma. So we have 2. So we send every patient to pain and palliative care center, and they get registered there. So they talk to these patients initially, because not only patient has a problem of malignancy, but he does have some social or some financial or some economical issues, or most of our patients are having pain. So one thing I wish to highlight is that when I visited Pallium India, I was also of opinion that if we give morphine to a patient, then it is then that is the end of road actually. So when I visited Pallium in Kerala and interacted with people there, especially Dr. Raja Gopal and Dr. Shalini Menon, and also there was one physician who took our class actually, Dr. Babu or something.
Dr. Sunil Kumar, who's our additional director, and Babu Ibrahim, who's our social worker.
Yeah, there was one who took the class on constipation and the pain.
Okay, must be Dr. Sunil Kumar.
Dr. Sunil Kumar from SP. So after that session, it opened my eyes that it is not the morphine we have started, and that is the end of road for the patient. Actually, that is what we used to think. But now we start, if the patient is having that much pain, then we start with the morphine. Patient gets relief from the pain, and after treatment, when his symptoms improve, we backtrack to ladder 1, step 1 of the pain ladder. So we do start it from step 3 to step, and we can come back to step 1. And that is one thing that has made a drastic improvement in our care. Not in my care, not in my practice, but also with the practice of our colleagues who are working in radiation oncology or medical oncology and taking care of cancer patients. Further, with the help of Pallium India and Sikla Foundation, we have started a home care visiting, home care team, which also which goes to people who are not able to come to us because of any problem. It may be because of it can be because of their financial, or there is nobody to take care. So we should be moving. This is what I think we should be moving. If you are starting palliative care center or palliative care in your center, we should start first with taking care of the patient who are coming to us, and then we should further increase our spectrum of patients with the help of, because we do work in a medical college and we get patients from every year. So not only oncology patients, but for palliative care, I have met people in medicine, people working in urology. So they send their patients who are suffering from stroke and paralysis or paralysis, and these patients are also taken care by palliative care, our pain and palliative care center. So they are doing a very, I think, a very good job. Further, availability of morphine, which is a big issue, but fortunately, we never had this issue in our department at least. We always had morphine in our department, and we dispense morphine in a fixed pattern. And the morphine is there with our senior resident. It is kept in lock and key under observation of a senior resident who only gives morphine after receiving the prescription, and he enters and take care of the entries in the different registers. And the main store or the main bulk of morphine is with me only. It is in my room only, in a storeroom just behind my room. So we supply the morphine as and when the requirement comes from our senior resident, and they take care of the dispensing. Also, in all the medical colleges where our residents have gone or consultants are there, morphine is available. In Tanda, in Mandi, in Hamirpur River. So in all the centers, this morphine is available. Moreover, I have made a point that whenever our resident joins, any resident joins, because every year we get 4 residents, new residents. So we make it a point that Dr. Sonia takes one palliative pain and palliative care lectures of these residents. So they are aware of the pain and palliative care center also, and how we should move about in resisting and caring of these patients and taking care of their special or the needs regarding their pain treatment or palliative care treatment. So most of our residents are also trained, and we make it a point that they get a certificate, which is a IAPC certificate, Indian Association of Palliative Care certificate. So we ask them to enroll in that IAPC certificate course, which is mostly done through PGI, and there is only 2-day contact program, and they have to take up tests, and then they get the certificate for palliative care. So they are informed as well, and they know how to practice the palliative care in their center or the centers they are going to move after completing their post-graduation. So that is all which I wish to convey to you, and thank you for having me on this platform.
Thank you so much, sir, for sharing your valuable experience through in palliative care and the lovely work that you and Dr. Soumya are doing there in IJMC. Great to hear that morphine is already available in Tanda and Mandi also, Medical College. We would really request Dr. Gopal Chauhan to make sure that wherever the trainings are happening, wherever the doctors are ready to have palliative care centers, we also have morphine available. We would want to work with the teams to ensure that there is no pilferage, there's proper documentation maintained. Our teams will work with your teams, but that's a request that I think we have to have this pain relief medicine, oral morphine available at the places where doctors are ready to take that responsibility. So we just thank Dr. Manish for a lovely experience sharing. Jatin, what's our next move?
Yes. So thank you so much, Dr. Manish. And now I would like to request Dr. Aditi Chaturvedi to begin with the presentation. Dr. Aditi Chaturvedi is an MD in pharmacology and a fellow in palliative medicine. She works as a palliative care physician at Chamba, Himachal Pradesh, and she's offering home care services to palliative care patients. She's also the professor and head in pharmacology at Pandit Jawaharlal Nehru Government Medical College, Chamba. She was the project consultant for the Ganga Prem Hospice Pallium India statewide spread of palliative care in Uttarakhand. She was the coordinator for the IAPC certified palliative care courses for the government of Uttarakhand. And she was also the mentor of the Asia Pacific Hospice and Palliative Care Network. That was a CTC project for developing palliative care at AIIMS Rishikesh. And Shalini, if you would like to add anything to introduce Dr. Aditi.
Thank you, Jatin. I just feel like talking more and more. Dr. Aditi, you're muted, but you'll have to stay muted for 1 more minute till I add something more to your profile. So to everyone, Dr. Aditi has been a palliative care advocate, consultant, I don't know, a promoter, whatever name you can give it to her. She has been in the forefront in spreading palliative care in Uttarakhand as long as she was working with Ganga Prem Hospice. She was our consultant and project lead. She worked with the drug controller. She worked with the National Health Mission, tried to bring up palliative care, take sessions, send letters to them that how important morphine is. And Pallium India got a chance to work with her, and just we worked together for the availability of palliative care and morphine in the state of Uttarakhand. And thanks to all your efforts, Dr. Aditi, Uttarakhand is also doing well now. And we are trying to do more with the National Health Mission there. But we are so happy when one sadness was that she's leaving Uttarakhand when she got shifted to Chamba. But we were happy that someone like her is also moving to Himachal, so that now we can strengthen Himachal's palliative care services more. And in her capacity, what she's doing in Chamba Medical College right now is completely volunteerism. I think she's going to share more about her volunteer activities, but that's in a personal capacity that she has been doing. So we want to hear more from you, Dr. Aditi. Very happy to welcome you to this session.
Thank you so much, Shalini and Jatin, for this introduction. So let's have the slides. So am I audible to everyone? Can you hear me well? Yes.
Yes. Thank you.
So I'm so happy that Himachal is progressing and developing palliative care services under the able leadership of Dr. Gopal Chauhan. So when I thought should I initiate, because this is something I love to do and I really want should develop across the country, because as we all know, mortality is 100%. All of us are going to die one day. So I'm also concerned for myself that when I am on my bed, there will be a 10% chance that I will go quickly. But then there will be a 90% chance that I might not go quickly and I will be bedridden. So I want that I should have a good support team. I should have a good palliative care service available around my vicinity where people are caring, they are giving companionship. I have no pain, I have no breathlessness, and I can go smoothly from this journey of life. So what we have started at Chamba is that I'm also associated with Art of Living organization. And a few of our members, I spoke and gave an introductory talk about art of palliative care to them. And they were motivated to work together for home-based palliative care for the patients. So we all just searched and started to find out patients. So what is home-based palliative care? This is the horizon where we continue to care when treatment also stops. So this is a long-term care model. Palliative care itself is a long-term care model, but this home care, it actually is to reach out to the homes of the patients. So next slide, please. So bedridden patients and caregivers, they all need very constant guidance, support, and training to empower them to take care of their loved ones. They don't know what happens when a bed sore occurs. They think that it will go on its own, but it continues to increase in size, and then bad smell comes and they don't know how to manage. So they need constant guidance. But when they feel that the doors have been shut by the doctor ki ab aur kuch treatment nahi hai, they don't know that they have something else also in hand, and that is palliative care. And I hope that all of us who are attending this session now will always be vigilant to offer palliative care to people who need them. In OPD or in wards, if you see any such patient, we ensure that when they leave the ward or the OPD, someone has trained them of how to take care of themselves, manage bed sores, and if they are in pain, that they can come back and visit the OPD and hospitals and take consultations. And let us hope that some home care will start soon at other areas also, apart from Shimla, Tanda. And as you all are here, so with the support of ANMs and ASHA workers, we are able to reach out in the houses of such people. They have been called as hidden lives, the lives who are unreachable, and they die in the four walls of the room. So next slide, please. So need for acceptance to these new care models is this: as the diseases are changing, we need to change the way we look at them also. So because chronic conditions, and as Dr. Gopal has told, that old age is also becoming a big issue because of our good cure rates and increased survival. Old age is also rising. So please continue. Palliative care now is the long-term care model for both. Next slide. So I will be sharing 3 stories because Dr. Parul has already given you an overview of what is in palliative care. And Manish sir has already shared of how he has developed the palliative care in Shimla and in other areas of Himachal Pradesh. So I will bring your focus now to the individualized, personalized patient care of home care stories of 3 patients which we have seen. So please press the slides. Yes. So yes, the third one also. So patient 1, the identifications have been hidden. So patient CD, she was from Tisa, and she was a 57-year-old lady with adrenocortical tumor and bony mets. Our another patient, second patient, will be from Rupani. He's there with us now also. 55-year-old man who had a fall from a tree and D5 burst fracture and paraplegia. And another patient who's passed away, she was in Utip, Chamba, 63-year-old lady, metastatic adenocarcinoma of the ovaries with malignant ascites. So if time permits, I'll try to cover the 3 stories, but if not possible, I'll bring the crux to you. Let's start with the first story. Next slide, please. Yes. So this adrenocortical tumor, we have limited photographs with our patients. The issue was that because this service that we have started is very, very new, and we want people to have faith on us and not just click photographs when they are not in a good position, good state. So we have very limited photographs that I will be able to show you. Next. Yes. So how I happened to meet this patient was in an Art of Living program where a son of Mrs. CD, he told us that her mother was in a very, very bad condition, having a big bed sore, extreme pain, not able to sleep at night, and this distresses him a lot. So this patient, Mrs. CD, she was operated for left adrenocortical carcinoma, and her CT scan showed that she has metastatic masses in D11, L5, S1 vertebrae area, and she was bedridden since 6 months. Next slide, please. So yes, next. Yes. Yes, the whole slide. Yeah. So as I've already told you about the chief complaints, that she had pain, she had anxiety, inability to sleep, then a painful bed sore. And because of the bed sore and the smell she was having, she was not able to sleep properly. And her pain was not allowing her to sleep. Her primary caregiver was this man's wife, who thought that her mother-in-law has something contagious and infectious, and if she takes care of this of mother-in-law, then then it might spread to her also. So next slide, please. So the palliative home care team, we reached out, and then we identified that there was a bed sore of approximately 8 to 10 centimeters side on the right side of the lower back area, and the bed sore was filled with pus and smelling with bad odor. So we advised to clean the bed sore. We cleaned it with gauze and normal saline, taught them how to put Metrogel powder on the bed sore for 10 days. So tablets of Metrogel are available. You crush those tablets and liberally use it on the bed sore as it was smelling and having infection. Airbed was donated by our team of Art of Living. Next slide, please. So she was also advised of how to give massage on the back and how to 2-hourly change the position. And then the daughter-in-law was counseled that whatever the mother-in-law has, it is nothing contagious, and we are all there. We are all taking care of her, and you can also take care of this patient. So what happened with all of this intervention in the home care? That the pain got controlled with the regular 3-time daily use of tramadol with paracetamol. So I would like to make a comment for patients of palliative care who are in pain throughout. Most of them will be in continuous pain throughout the day. So it will be very, very helpful for all of you to use 24-hour pain relief rather than SOS and being worried about the side effects with the medicines, because those side effects are manageable, but the pain is making them anxious, then they are not able to sleep, and the whole quality of life, it deteriorates. So tablet, lorazepam, and then Yog Nidra meditation was advised. Bed sore smell improved after 10 days, and because of all of this, she was able to eat. She was not anxious anymore. She was able to sleep well, and she had no pain. So daughter-in-law was trained to take care, how to clean the mother-in-law, and videos and images were provided of how to treat the bed sore and how to take care of the patient. Yes, further slides. Yes. Next slides, please. So then what started to happen was that Mrs. CD, she started to feel that she's cured of her illness. She thought there is no more illness and I want to get my CT scan done. And CT scan done nearest was at 3 hours away from where she lives. So the team, they insisted that there is no need for CT scan and you should be restful and you should not be worried about the CT scan. But it appeared that she really was believing that she's getting cured, and she took a vehicle and got down to Chamba and got her CT scan done. But accidentally what happened was that on the way the roads were so bad that she got once half-sided paraplegia, and it appeared that maybe this was an episode of stroke which happened to her. Next slide, please. So it was reported by the son, Mr. BR, that she was admitted to the casualty due to the paralysis of one side of the body and was unable to swallow. The patient was taken back, and at home, the patient was not comfortable with the Ryle's tube, and the patient, she decided to remove the Ryle's tube. We had told the implications of removing the Ryle's tube could be that she could aspirate her food and aspirational pneumonia can occur. But even after that advice, the patient and the family decided to remove the Ryle's tube. And then she was back in pain, not able to swallow, and anxious again, not able to sleep. Next slide, please. And as she was not able to swallow much, pain increased, anxiety increased, and she could not sleep. Rectal administration of these medicines were advised to the family, but then they declined. And we tried hard that we should be able to arrange injectable tramadol and lorazepam from the local chemist at TISA, but and also the doctor at PHC TISA, he prescribed all these medicines, but nowhere around these medicines were available. Injectables were not available. And we then thought that we can transfer it from Chamba, but then the access that we could have was also very limited access, 3-4 ampules and not more than that. And that would have been sufficient only for 1 or 2 days. So our patient passed away on 15 September 2023. Son was very grateful for the support that we offered. And I'm quoting in verbatim of what the message I got. Please show me the next slide, please. नो यस दिस वन. सो दीदी मैं आपको बता नहीं पाया, हिम्मत नहीं रही कि माता जी सुबह 2 बजे 2:30 बजे के बीच उन्होंने अपनी देह त्याग दी. आपने जो सहयोग किया है, मैं आपका ऋणी हूँ, मैं आपका आभारी हूँ, आपका बहुत बहुत धन्यवाद. And things like this tell us that even when we are not able to cure the patient, we do make a difference. We do really make a difference to those whom we are not able to cure also. Though at my heart, I knew something more could have been done. I was not comfortable at it, that the end was not as I had thought it could have been, with all the best support and a good palliative care network, if we could have had all the doctors well connected and all the medicines well available. So, but it was not what we could have achieved for this patient, but they still were very, very grateful that we offered them companionship till the end. Next slide. So we decided to take a feedback of our service that we offered. Next slide, please. Yes. So did the service help you? So they told us that, yes, of course, she helped financially. She provided an air mattress. It was a privilege. Financial advice was given. Next slide, please. So what more would you have expected from this service that we offered? So this is from the patient and their son, his sons. This is from the user end, consumer end's mouth. Healthcare, regular checkups, we need this. Personal care, we need this. Physical, emotional support, and companionship. This is what they have written when this was offered to the patient. If you rate, they've rated it 10 out of 10, but it is not true. It could have been 10 out of 10 for me, for my satisfaction, only if I could have been able to offer a good end of life, a pain-free, anxious-free, breathlessness-free end of life. I would have rated myself 10 on 10, but this was not 10 on 10 for me. But of nothing being available and what we offered, they were really grateful. So this was the feedback. Next slide, please. So our limitations were that we tried to support the patient, but there was lack of access to the strong painkillers. There was lack of access to the injectable anti-anxiety drugs in the local area. Support in the end was not adequate as per our understanding. Next slide, please. And this was our conclusion for our patient, that the support was not enough. We were left in the guilt of not offering adequate support. And we sincerely hope that with you, all of us together, all working it together as a team, we will be able to make available all the medicines that are needed for palliative care. Next slide. I'll be quick with the further patients. Another patient, fall and paraplegia for Mr. RC. Next slide. So Rupni Chamba, this was the area. This man suddenly had a fall from a tree. He was a carpenter doing woodwork. So from the tree he fell and there was a burst D5 fracture with paraplegia. Next slide, please. So because this happened suddenly, it drastically affected his living. So when we visited the patient, he was all very angry, not wanting to talk, and also making fun that what help can you offer to us? We are in such pitiable situation. Next slide, please. So the patients, they can really go, they can really be angry also at you sometimes. So because patient had to leave the job, should I be quick?
No, Dr. Aditi, actually, you have enough time. Please go ahead and take your time. I think we would like to listen to these stories in detail.
Okay.
Would like to listen to you completely. Yeah, thank you.
So, so this man, he had because now he is no more a carpenter. That job is lost. Son had to leave his job and return back to the village because now a father was completely dependent on him. So both the bread earners, Mr. Prakash and his son, I should have actually hidden the identity. And so patient and his son, both of them, their family income reduced drastically, almost to zero, because now both the bread earners were at home. So on our first palliative care visit in 2023, the family was really not understanding what and how they can be of help to their father. And the patient conveyed, I don't need any sympathy of you. I don't want your sympathy, or I don't want you to pity on me. So this was what we heard from him. And then we tried to convince him that even though if we are not able to change and make you stand and make you become a carpenter again, but still there is a lot that we can do for you. And then we tried to explore of how and where does he need more help and how can we help. So he complained of bilateral radiating pain in both legs, and we started neuropathic painkillers for him. Next slide, please. Yes, please press more. Yes, the whole slide. Yeah. What we offered to him was that we facilitated his Sahara pension papers and helped him got approvals, where you can feel and see that even if you are not a doctor and you have support of volunteers around. Shri Hemant Puriji, a very strong Art of Living volunteer here, he helped with the approvals of his pension scheme. Red Cross Society was approached and a new wheelchair, the wheelchair was broken 2 years ago. He was issued a wheelchair which was used and now it was broken. They had no money to buy a new wheelchair. So the new wheelchair was given to them with the help of Red Cross Society. Medicines for neuropathic pain were started. And we guided him that if not big furniture, if he could, to pass his time, he can start preparing some small wooden work designs which can be sold to the tourists who come to visit to Chamba. And feedback after all that was offered, after 3 months, we took a feedback from the family and they reported that this support was really helpful. Distress thermometer was conducted and the scores reduced from a distress of 8. The patient reported earlier that he was out of 10, he was distressed 8 out of 10. And after our services, the distress reduced to 5 out of 10. And then the reasons for distress was identified, that he still believes that he can stand up and walk one day. So this is the main reason for his distress now, which is left. And though he has accepted that the chances of his walking and doing carpenter work back again are less, but we have not destroyed his hope, and we are with him, motivating him that he should do some physiotherapy exercises and do whatever he can to make himself more mobile and independent. Next slide, please. The current position is son and wife have started to earn. No, yes, this one. Family pension has started. Mr. PC has come to terms with this condition and the family appears settled. So this is how we made a difference to a paraplegic person in Chamba. Next slide, please. Story of Mrs. GD. Yes, next slide. So this is a 63-year-old lady with metastatic adenocarcinoma of the ovaries with malignant ascites, and she's no more with us now. Next, yes, the whole slide. Yeah. So yes, this much. Since 1 year from June 2022, Mrs. GD was bedridden. She complained of inability to swallow her food, nausea sensation, fullness in abdomen, constipation, and loss of appetite. So if you look at these symptoms, none of them appeared to me as, like malignant. There is some ascites. So why is she having nausea and is not able to swallow? So when we did an oral checkup and there was oral candidiasis and there was esophageal candidiasis, because of which she had extreme pain while swallowing even water. So this was something which was treatable and we were very happy about it. And then nausea was treatable. Fullness, we could not do much about it unless you drain the ascitic fluid. So we advised her to get the ascitic fluid drained at the hospital Chamba. And constipation was treatable. Loss of appetite, we explained that because of her advanced disease, even if she eats less frequent amounts, small meals, it will be very helpful for her. And the family should not waste energy forcing her to eat and making her feel guilty about not being able to eat as earlier. So loss of appetite was explained to the family and to Mrs. GD. So there was a lot that we could identify and help the patient. Though on seeing the diagnosis, it appeared that what if she is not treatable, what help could we have offered? But a lot of things were achievable for us to offer support. And on examination, oral candidiasis was present. There was a small bed sore, initiation of a bed sore, and we were very quick to identify and offer her a small air pillow so that she can change sides, put a pillow. There is no pressure there at the sacral area. Yes, next slide, please. The whole slide, yeah. So candid mouth paint to be applied 3 times a day after meals. This candid mouth paint, this generally has a very stringent irritant feeling. So therefore, mucin gel was advised so that it can coat the mouth. and then you apply the candid mouth paint. Mucin gel to be taken 10 minutes before applying candid mouth paint. Tablet fluconazole was given, metoclopramide for her vomiting was given, lactulose for constipation, aldiptone, spironolactone to manage her lot of fluid collection in the abdomen, that was given. Nutrition diet as advised by her oncologist was continued. They had advised high protein diet, so we asked her to continue that. And she was advised drainage of ascitic fluid at Medical College Chamba. So oral candidiasis improved, she was able to eat, nausea improved, she felt better, constipation relieved, and Mrs. GD started to eat frequent meals. Next slide, please. So collusion was addressed, though the relatives wanted that we should not convey to the patient that she has cancer, but we opened up the discussion that it will be good that she knows so that she can make her last goodbyes. She can relate of whatever she wants to tell to her son, and the son and the family can be more open in expressing their love to Mrs. GD. Loss of appetite due to advanced stages of cancer was, the advice was given that the family should not be too insisting on the meals which she used to take earlier. Eventually, Geeta ji started to decline food, and due to the floods in Ravi, if we all know that Himachal was in floods. So during that time, our next visit could not be done to Mrs. GD. And neither could we come, nor could she come to the hospital to get her fluid drained. And she stopped all medicines, and daughter-in-law was advised to allow moist cloth cotton wipes from the mouth and rectal lorazepam. They already had some lorazepam tablets, and rectal lorazepam tablets 2.5 mg to keep her calm and restful. Next slide, please. She passed away peacefully on 31st July 2023, and the family was very, very grateful, and her husband thanked that, conveying that even when they all knew that his wife could not be saved, and he felt so relieved and so supported with the visits that someone is concerned and we are not alone in this. So this sometimes when we feel that palliative care might be, this is optional or something which we can do away with, but it is not something which we can do away with, because mortality is 100%. You, I, all of us, we are going to go one day. Next slide, please. So we hope and we really look forward and we dream for a beautiful palliative care center coming up in Chamba and all across the state. Limitations were that we had rectal lorazepam was offered, but her fullness in abdomen, that could not be addressed adequately. Next slide. So the conclusion of what through all these stories and through whatever palliative care work I have been doing in Chamba is that this beautiful work of palliative care has started at Chamba with a willingness of a handful of people, and few of them are not even doctors, but there is just a willingness to help and be available. And I'm sure that all of us who are here in this presentation, we all have this willingness to be there for our patients. That is why we are here today listening to this presentation of palliative care. And death is 100% for all of us. So before our time comes, wouldn't we all like to be offered care and offered companionship as Mr. BR, son of Mrs. CD, he hopes for? And whatever is being offered here through this volunteer service, we don't think it is enough. Next slide, please. So our drive to continue, what makes us to continue when we know that this is only one or two, whatever stories we are sharing, and we have till now seen 15 to 20 patients. So out of the whole scenario of palliative care, the need is so huge. So, and then we sometimes feel, do we really make a difference to people around us? In Chamba itself, there are so many others who need, but we are not doing it. So then we remind ourselves of this starfish story, that there was a grandfather and a grandson, and the grandfather told that, son, you are putting one starfish back to the sea. So what difference it is going to make? This whole shore is flooded with the starfishes. So beautiful reply by the grandson that he puts one starfish back to the ocean and says, it makes a difference to this one. So we are contended somewhere that we made a difference to few people around in our community. Next. So yes, palliative care is everyone's business. Let us just accept this fact that it is right at our doors and it is our business. In our family, someone will be going. In our family, someone will be bedridden. So our goals for palliative care activities for Chamba district are that one day we hope that implementation of a good community-based palliative care setup in a PPP model with Chamba district, government hospital and the local NGOs working together to develop a good home-based palliative care involving the ASHA and the ANM workers. And we hope that training is ensured of doctors at Chamba. Next slide, please. And training of not only doctors, but nurses, the ASHA workers, the community volunteers at the tehsil level, they are trained in palliative care. Next, yeah. And appointment of a trained doctor with nurses at Chamba district. And we have a good OPD and then IPD palliative care settings and a palliative care, at least a 5-bedded palliative care wing in Chamba hospital. And then we do field monitoring, data collection and audits to improve our ongoing program. Next. And this is a small 2-day program that we can develop. This is just an idea for our ANM and ASHA workers, and we can train them in palliative care where they can help identify patients in need, and then the whole team can work to address the needs of such patients. But at least we have to start identifying more and more patients who need palliative care. Next. Yes, one more. So let's be the music in someone's life. Let's take this initiative, all of us together. A lot of us have started doing. Dr. Manish is doing great work, and Dr. Johan is there to guide us all. Pallium has joined Himachal to support the development of palliative care. So let us just take this initiative forward together and be an example for the whole country, like Kerala in the south. We can be there in the north to be there for our patients more and more and do good palliative care work. Thank you. I think thank you.
Thank you so much, Dr. Aditi. That was such a lovely session, and for the lovely stories that you shared. That अगर हम एक patient की भी मदद करते हैं, तो that itself is such a great satisfaction we get. So I think Jatin, all over to you.
Thank you so much, Dr. Aditi, for this wonderful presentation. Now, I would like to thank all our speakers for giving such insightful presentations and lectures and providing an overview about palliative care and how it can be effectively provided to the patients in need. Now, I would like to request Dr. Gopal Chauhan, sir, if he has any thoughts or suggestions to share, especially after listening to Dr. Aditi and Dr. Manish. Sir, please.
Yes, thank you, Dr. Jatin. And really, the start is very good. And I hope that it will give us a lot of, positives today. I would like to say that, for us even, we have experience of 3-4 years running this palliative care program in Himachal Pradesh. As you all know that we started it in the year 2018. We sent few doctors to Trivandrum, few staff nurses also. And in 11 places we could start the services, and in many places the we could not sustain it, I would like to say that. But in Bilaspur we can see that 207 OPD patients has been registered there, and at Hamirpur 14, Kangra 241, Kullu 191, Mandi 147, Rampur 18, Rodu 6, RS Solan 183, Unna 281, Nahan 87, and IGMC Shimla, they are having their full-fledged unit. These are OPD patients, and indoor patients 25 in Bilaspur, 0 in Hamirpur, 118 in Kangra, 0 in Kinnaur, 115 in Kullu, 84 Mandi, 0 Rampur, 0 Rodu, RS Solo 97, Unna 12, Nahan 0, and IGMC Shimla, they are having indoor unit facilities also. I think that we are having some experience of running this palliative care program. And about availability of morphine as of today, we are having available at Kangra, Dharamshala, Kullu, Mandi, Rampur, and Una, and IGMC Shimla, of course, and Tanda. Uh, we can say that we have some experience, but now we need to excel this, and we need to demonstrate that how the best practices comes from the states. It should be upward trend, and our plan is very clear. First of all, we will identify two medical officers in each institute in first phase in the district hospitals, and 2 to 4 staff nurses in each hospital. They will be trained by the Pallium India team, theoretical as well as practical training. After that, we will be fulfilling the gap of infrastructure requirement. We will identify the wards where the money has not been spent, which we have given to the districts and institutes. We will request them to pool some resources so that they can establish the palliative care ward in the institute. And then about the availability of the drugs, I'm pretty sure that it is part of our EDL, and the morphine, availability will be ensured in all the institutes. But we have to be very careful, which is a schedule H drug, and there is a strict monitoring of this drug. It is not like PCM tablet that you can keep it everywhere. We have to follow some standard protocol for placing the indent, and then dispensing the drug and monitoring the drug also. We have to be a bit careful, but I assure you that this will be available from our side. And I think that the plan will be ready in the month of April, and we will start our trainings, I think, very, very soon. Over to you, Jatin. Thank you.
Thank you so much, sir. Now the platform is now open for discussions and interactions. If anybody has any query or want to ask anything or want to share anything, you can please proceed.
Probably
Also
I
see
can.
Dr. Harsharan Kaur in the audience.
Dr. Harsharan Kaur, can you hear us?
I don't think.
Okay.
Yeah.
I would
She's
just
the
call out.
ex-principal of Parimahal, and she's also the Deputy Director of Health Services, Himachal earlier. Yeah, please, Shalin.
Sorry, Jatin, I think we have, I don't see Dr. Harsharan Kaur here. Probably if you see her again on the list, then we can invite her again to share her experience. But I would really want to call out if there is any of the doctors who had visited Trivandrum and who has joined today earlier, like any of the district hospital doctors who have had an experience of running a palliative care center. What has been your experience? What are the challenges you're facing on ground? Because I think this is the right platform to discuss about it, and so that we, along with wherever as an NGO we can contribute, as a administrator, Dr. Gopal Chauhan can contribute. We can discuss the plan further, as he just mentioned. So I would really request any questions, please come forward and ask to the faculty or to any of us.
Shalini, I would like to add a few more points here.
Sure.
What we will do, we have a WhatsApp group, we can seek the comments on that also, and we will be talking to this person in person also. But more important is, we should prepare the plan that what we need to do in the month of it. It may be like a Gantt chart, that what is expected to be done in the month of April, what will be done in the month of May, and in June, so that we will circulate that plan to them, that this is our plan, and if you want to do some additions, that can be done. Because once our plan is clear, uh, then we can proceed as per the planned activities. But the plan should, I request Jatin to prepare that draft plan, month-wise activities, that in which month we will be meeting, where to meet, how many online workshops has to be organized. But today, I think the concept is clear. uh, we are having a very good participation from all the districts, and Dr. Parul, Dr. Manish, Dr. Aditi, they are our experts. And I think Dr. Somya, we missed him today, but he will be available in the next sessions. This will be a combo kind of pack. It will be not a one way flow of communication, that we listen to the experts only. More importantly, we want the comments from the implementers, those who will be implementing all these strategies at field level, institute level, what problem they will be facing there. I think the tentative plan will be circulated to all through a WhatsApp group, maybe a email group, and so that we can invite comments on that, and after that we will start the activities. I think, is that okay, Jatin, for you? This is exercise for you, and
Yes,
please do it within a week time, so that we should not delay it further.
sure,
And
sure,
all
sir.
the administrative decision can be taken up within the code of conduct, and we will start those activities, IEC kind of things, after the code of conduct is over. But the
Definitely, sir.
activities before that, we can definitely do the trainings, the IEC material. We can prepare that, but we'll circulate that after that. But
Hmm.
before that, we will start the theoretical and practical trainings.
Sure, sir.
Sure, Dr. Gopal. I think that's the right way to go about it. We'll definitely, Jatin will share the plan with you. We will have a combination of online trainings, on-site trainings in Trivandrum, as well as in Parimahal or in any city or district you would want in Himachal. We would also, as we have shared, we would want to do an implementation team also. But that wherein a team will come and work with every doctor and nurse, whosoever is interested to operationalize the palliative care center. Pallium India would like to work with you hand in hand and help you open up that center. At the same time, whichever things we have already conducted an opioid availability workshop in the month of November. We did that, Dr. Jatin, with
Yes,
Mr.
November.
Navneet Marwa. Yeah, we conducted a workshop, and a similar workshop we can do it for everybody here, so everybody understands the seriousness of maintaining documentation for the required pain relief medicine. So we want to have a balance between availability as well as no pilferage. So we'll send you the plan in a month. But if you have any suggestions, still I'm calling out to everyone. If anybody has a question right now, anything about palliative care, you can go to our website as well, Pallium India website. We offer courses from all 10 days to 6 weeks to specialized courses. You can go and enroll yourself directly also. But Dr. Gopal would be definitely ready to help if there is any particular course required. Dr. Gopal, go ahead. You have raised your hand.
Yes, Chalini, one thing which I missed to speak.
Mhm.
What happens whenever we are doing some collaboration with any NGO or organization, we start working without any baseline kind of data. Okay. I think that this is the right time that we do some baseline assessment, so that the model is a replicable model, it is scientific model. That what was the situation in Himachal Pradesh when we started it in 2024, the baseline scientific assessment. Okay, that what is at ground level, availability of morphine. What I'm saying may not be right. What is the ground realities, the situation. It should be a scientific kind of evaluation, and we will publish that, so that to make it a public document, so that other can also follow. First of all, we have to do the baseline assessment, uh, that what is there as on today, and what happened after all those interventions. And we will beat that, maybe after 6 months or after 1 year, that this is the difference. And after 1 year, we may say that we have established the right setup. I think if you agree, if the research can be done through your institute, it will be better, because we may be biased for that. But if you ask us, then we can call our medical colleges, the PG students, they can also do this study for us. The baseline assessment of palliative care, against the standard protocol, that what is required and what is there in Himachal Pradesh. Because whatever intervention we have done in past, there is a lack of this component, that we don't do the baseline research, and even we don't publish those research. that what is the reality. I think this is the missing part, and this will open the eyes, and we can do better definitely.
Wonderful suggestion, Dr. Gopal, and thanks for bringing that up. We definitely would involve our research team, and we have already developed a quality assessment tool for assessing every palliative care center, where they are with respect to different aspects of running a center. So we can have a combined call, and we can look forward, create a baseline assessment, and then look forward for the plan. Accordingly, develop a plan how we are going to go about. So I think that's a lovely suggestion, Dr. Jatin. Let's work on that with our research head, and probably, Himachal would lead the way for other states to start following the same process. So thank you so much for that suggestion. I do see a hand raised by Dr. Harsharan Kaur. Ma'am, we were looking for you. Please go ahead. Ma'am, can you hear us? I think she must be having connectivity issue, because now I don't see the hand was raised. She wanted to say something probably. So I think the first point, Dr. Gopal, is let's have a discussion with our research team and our quality team, and we'll do a baseline assessment for all your centers. We would need your help also on that, to have a list of centers that you feel should be reviewed and audited, and to check where, at what level it is existing. And of course, your approval to visit those centers with that respect. We will put in a proposal with the requirements, and then you can work through it.
Okay,
We'll put
please
it in
try
a-
to make it, part of that, the plan of activities that, this is the
Definitely,
first thing.
definitely.
Because we did same thing for tobacco control. We missed it for
Okay.
many programs.
Okay.
And
okay.
this is the reason that we could sustain the tobacco control activities, because we did the baseline assessment, and we are, comparing that what progress has happened, after that. This will be very, very important.
That is definitely, there is already a gap assessment happening by us for a lot of institutes. Many institutes, we go and visit us and do a gap assessment first, and then our quality team goes and implementation team goes and tries to help them pull up. So I think you're showing the right way. We are all ready for that, and we'll put it in the plan of activities and take it further with all the centers here.
Yes, Dr. Suresh, you would like to say something from Kullu? Because at one point of time, Kullu was working very good. Dr. Suresh, please. Are you in?
Dr. Suresh, can you hear us?
I think
No. Dr. Harsharan Kaur, I saw your name. Can you hear us? Oh, if by chance you're not able to say it out and we are not able to hear, if you could just put it down, your thoughts in the chat box, and we would call it out. I think Dr. Kaur cannot hear us, or is having some network issues. Anyone else you would like to call out, Dr. Gopal, to share their thoughts?
DPO Solan and DPO Mandi.
I see DPO Hamirpur, DPO Kangra, and DPO.
Yes,
Yeah.
we are having Dr. Anuradha from Mandi, and her, inputs are always valuable for us.
Thank you, Dr. Gopal,
Please,
and
ma'am.
good afternoon to everyone. As you know, Dr. Gopal, palliative care मेरे पास last year नहीं था, and recently I have been given this program. लेकिन आज के जितने भी speakers थे, I have listened to all of them. मुझे ये लगता है कि अभी तक हमारा जो palliative care था, we were running it in the institutions mostly. और ये जो community को involve करने का concept है, वो शायद हमारे state में नहीं था. I think, I hope I'm not wrong.
You're right, ma'am.
Yeah. So thank you, Rakshalini. So what I feel is कि हमारी trainings जो भी हम plan करेंगे for this financial year, सिर्फ institutions तक limit ना हो करके, I think community involvement जो है, that is much more important, because facilities पे तो I think बहुत कम patient आकर के facilities को avail कर पाते हैं. सो आई थिंक इसके अलावा अभी तक मेरे पास इतना इस प्रोग्राम के बारे में इतनी ज़्यादा जानकारी नहीं है कि मैं और ज़्यादा इनपुट्स दे सकूं. But I think involvement of community, involvement of families and the caretakers, उसके ऊपर भी हमारा फोकस होना चाहिए जब भी हम अपनी ट्रेनिंग्स जो प्लान करते हैं. So
But
that is all I have to say. Thank you.
one thing I want to add. Hello.
Yeah, please go
Yes,
ahead.
sir. Please, please.
Hello, sir. Actually, we have imparted the training to the medical officers, and we directed them to provide the services at the field level through the CHO and medical officer for the critically ill patients also. And they were given the incentive at the rate of 250 rupee per visit. We are involving the community also.
Yes, sir.
Great, great.
Dr. Anuradha, as per the program guidelines, all the MOs were to be trained, CHOs were to be trained, staff nurses at PSC level, at sub-center level, and they will then guide the community as per the guidelines that how to mobilize the patient, who has to be mobilized. And there is a concept under palliative care also to provide 250 rupees to the health service provider if they are visiting to the houses. But there is a very less expenditure because we could not scale it up.
Actually, we have flagged this message to the BMOs and directed to book this fund. But how much they have booked this fund and utilized this fund, that will be discussed in this monthly meeting.
Yes, sir. Yes, sir. Yes, sir.
That's such a lovely, lovely suggestion, Dr. Anuradha, and thanks for bringing that up. I think that's what Dr. Aditi highlighted also, that community has to be involved. Otherwise, the amount of population and the burden that comes on our
That's
government
right.
institute is too huge. But yes, the leadership is required from the center. Doctors like you in positions who can influence the community and who can involve the volunteers in the community to come up and join hands with you. And of course, the programs like what Dr. Gopal has mentioned, those programs can be further enhanced and requested for. Like right now, probably you didn't know that guideline, but tomorrow, if you know that guideline, if you have a plan, you can always request that budget, and accordingly, that can be planned for the coming months or the years. So I'm sure Dr. Gopal would support all the requests, at least put it in the PIP for the next year, if possible, if not this year. Dr. Aditi, you wanted to say something?
Yes, a quick thing that ANM and ASHA worker training should not be underestimated. We really need to bring up the ground workers who are there already in the field, and they might not be given extra incentives also maybe. So maybe we need to incentivize this, what already the ASHA workers and ANMs are doing. They can be trained well to manage the bed sores, give good nursing home care, how to clean the patient, how to offer oral care, and how to take care of the bedridden should be a very, very structured thing of how they should be taught. And lot of the doctor's burden can be managed at the level of ANM and ASHA workers. The BMO and other doctors can just keep a record of what is the list of our patients, what care you are offering, and so on. If this is my understanding, if I don't know how it goes. Sir, would you like to add something to this, Gopal sir?
Yes, our target was to train all the doctors last year also, and last year to all the CHOs, all the ANMs. It is a part of the 12 package services in the health wellness center also. We have to train the team. It will include ASHA, ANM, CHO, and the MO. And as per the report, we have completed the training of, I am compiling the report till 31st of March. We have completed the training of, around about 50% of the entire, staff, because we are having 8,000 ASHAs and around about 2,000 ANMs and around about 1,000, staff nurses to be trained apart from district hospitals at peripheral level. And I think let us see the report that how many are trained, but I am not sure about the quality of training, because how did we train them? Government of India has a module for palliative care as well as for elderly care. It is a 4-day module. In 2 days, we have to train people for palliative care. In next 2 days, they have to be trained for the elderly care. And the TOTs were trained in Delhi. Then we trained the district TOTs at Parimahal. People, 2 persons, 4 persons from every district were called to Parimahal for 4-day trainings. After that, they were sent back to train MOs in a cascade manner. They will impart the training further. But like this, the training get diluted. The quality of training was compromised. We can understand. And somehow during COVID, we trained people online also, which is not a, I think, right forum for trainings, for all trainings. It will be a value addition, but it should not be supplemented by the physical interaction. I think we will improve the training, and by end of this year, I think in Himachal Pradesh, everybody will be trained in palliative care. Thank you.
That's such a great thing to hear, sir. This year, at least, will ensure the trainings. We'll make that part of the plan. Any other suggestions from anyone? I believe, yeah, go ahead.
Sir, the one request, Dr. Gopal, please put the training for this year PIP for the training to the ENM and CHOs. And it should be clearly mentioned how many days training to be imparted to the ENMs and CHOs and MOs. We have imparted for 3 days training during this year. Palliative care as well as elderly care. We mixed both the training and imparted for 3 days training. It was a 3-day duration, sir.
Yes, sir. Government of India changed the guidelines. During the COVID period, they said that, online training are enough. After that, they said that, the physical training has to be, done. But, this year, as per the Government of India directions, 2+2 days, I think this is as per the guidelines. And the modules are with the TOTs, and the TOTs are there. Few have been transferred, but we are still having the list of those TOTs. We will do the, training of the TOTs again. Online orientation kind of thing for 1 hour, so that they can restart the training, sir. We will fix the timelines and mention in that letter also. Thank you.
I would like to suggest something here, Dr. Chauhan. We have done CHO trainings for a couple of states, and all the CHOs, like wherever is possible, they have a good network. They can do an online training, on-site training. We would love to come and do and join hands with your train the trainers group also, and help them conduct those trainings. But that might require a larger amount of visits from our side, which can be expensive. But the online trainings we can conduct, where we can handle a batch of probably 50 to 60 in one batch, and we can conduct those trainings.
Yes, Shalini. We
So
can
you have
do.
up to 100
What
participants.
happens, Government of India is having different divisions: palliative care division, elderly care division, cancer care division, eye care, oral care, ENT, emergency, ERT division. They think that, whatever we are deciding here, it will be implemented in letter and spirit. You see that, under palliative care, the training for palliative and elderly care is 4 days for MO, 5 days for CHO, 4 days for MPW, and 5 days for ASHA. But practically, it is not possible, to spare a person, CHO, ASHA for 5 days for this training, and 5 days for oral care training, 5 days for ENT training, then eye care training. Then we have to customize the trainings. This is what is the problem with the field level officers. We are having, I think, one doctor in a PSC, and you are sending him for trainings for 6 months, 5 days. I have only shortlisted 4 or 5 programs. We are having an entire list of multiple programs in the state. This is a problem with Government of India, I would like to say. But what will happen after this customization which we are doing with Pallium India? We will say that 1 hour training, 1 day training, 2 day training is sufficient for this one, and we will doing the assessment for that. That will make the scientific basis for other states also. Otherwise, every state is suffering like this. If we train people as per the Government of India modules, it will take more than 6 months.
We agree with you, Dr. Gopal. These are some of the practical challenges every state is facing. So we will have a hybrid model, I would suggest, wherever possible, online sessions for the theory classes, and then hands-on training where we can train the people. And wherever possible, we will go to the centers so that they don't have to leave their centers and come at one place for the trainings. Wherever possible, our faculty will go there, be there with them, and try to join hands in their situations and manage things in their. That's what the implementation team concept has been. So I think there's a lot more to create and work together. We will make a plan and share with you. Unless there is something more, there is still time to discuss. If there are any more thoughts, I see that Dr. Harshankar has given her gratitude and shown her gratitude to faculty, as well as Dr. Chauhan, you and all of us, to be here and having this discussion. And Dr. Aditi has mentioned that we might also prepare a structured training program from Pallium to NMs and ASHA workers. Sure, Dr. Aditi, that's already in plan. We haven't yet actually delivered with an NHM. However, CHO program has already been delivered, because earlier, I think this program was being done by the NHSRC along with the state NHMs. So now it has come to us that we can also get involved in ASHA's and ANM's trainings. So if the state of Himachal invites us to do that, we would be happy to create a whole structured program for it. Great, I think lovely discussions. Dr. Jatin, is there anything that we missed out?
No, Shalini, I think that is all. And if nobody has any more thoughts or suggestions, sir, can we conclude the session?
Sure, sure.
Okay, then thank you so much to everyone. Thanks to Dr. Gopal especially for taking the initiative of organizing this session. I believe it was a great meeting today and listening to everybody's thoughts and suggestions. They were very insightful, and hopefully we'll have some of more these sessions coming forward in the coming days. And we'll definitely work on whatever suggestions you have given, Dr. Gopal. We'll plan accordingly as per your suggestions, and we'll come back to you with all our plans and proposals. So I would like to thank everybody for joining in, and have a great day. Thank you so much, everyone. We'll log out now.
Thank you,
Thank
Dr.
you,
Jatin,
thank you.
for arranging. Dr. Gopal Chauhan, we want this program to be your TV program, making you win some awards for palliative care also.
We have received more awards in NCD program.
For sure, we would look
And
forward
there
to
is
that.
a visual impact also in TV. There is no visual impact. The TV has increased from 207 to 211 in last 10 years. But in NCDs there is overall progress. The incidence is coming down, and I think that our palliative care model will be the best model in India.
We look forward to working with you more on this. Thank you so much for this initiative.
Thank you. Thank you.
Thank you to all the faculty. Thank you, Jatin, and all the participants. Thanks for joining in.
Thank you,
Thanks,
sir.
Shalini.
Have a lovely day. Bye-bye.